Donna, the only thing I would add to it is, as somebody who is here in Washington all the time and gets paid to do that, is we continue to remind both our Democratic and Republican friends that the issue here is, as Antonio and Ivan described it, and that is that it is both an individual need to get high-quality, affordable health care and an economic imperative for companies to have it be affordable so that we can compete. The message has been consistently, as the study that Hewitt worked with us on, is that if we do nothing, we are jeopardizing our ability to compete in the international marketplace, and that is unacceptable. We need to do the right thing, and we need to do it quickly. Next question, Brad.
Our next question is from William Astor of the Rochester Business Journal. Your line is open.
Yeah, hi. I was cut off for a while, so I'm not sure if my question might have been answered, but I would like some elucidation on the BRT's problems with the public option. Is that based on political and or ideological concerns, or do you have data that show that it wouldn't work? And if so, what are they?
But Ivan or Antonio?
No, I think Antonio gets this one.
Yeah.
I see. John, you start with this.
All right. William, there are three basic problems that we see with the public option, the way that it is structured. First, governments and government-run plans, we know from our Medicare experience, just can't innovate. And the key to bending the cost curve, if you will, is to get consumers, get providers, get payers together to do the kind of innovative things that many of our companies do, focusing on wellness, focusing on prevention, focusing on better information for the consumer in terms of cost and quality, more participation of the consumer in healthy lifestyles and individuals in healthy lifestyles, that we've run up against, that when we go to providers and ask them to be more creative, they say we'd like to, but Medicare won't let us. So perpetuating and adding to a system that has failed to be able to demonstrate the kind of innovation and creativity that can bend the cost curve is our first problem, and that's what we see in the public plan. The second problem with the public plan as it's constructed is it continues and exacerbates the cost shift. The public plan, by design, particularly in the House bill, underpays the providers in terms of the cost of providing the service. And we know what happens now when providers are under-reimbursed through Medicare and Medicaid. They have to get the cost somewhere, and they go to those who pay, the preponderance of which are employers. The third is a concern that the public plan is structured so to provide a subsidized rate, and we're concerned that that could draw away some of the people in our system now, in the insurance system. About 10% has been estimated, I think, by CBO, and we lose the younger, healthier people that make our risk pools work. So by design, for those three reasons, the health care option that is the public plan option that's in the House bill takes the existing system and makes it much worse for those of us who pay and for employers. Next, did I answer your question, William?
Yeah, I would just have one follow-up. I believe I heard the other day, as to your first point, that there was a recent poll that showed that 70 to 90% of doctors did support a public option. I'd be curious as to why, if they have so many problems with the Medicare system, they would support a public option. Such large numbers.
You know, I can't answer that. I think you have to ask the doctors. I'm a little confused of where they are now. Some people say they're in favor of it. Some people say they're opposed to it. There's a lot of noise around it, but you'd have to ask the docs.
Okay.
Yeah.
All right.
All right. Brad, next question.
Our next question is from Joyce Frieden of Internal Medicine News. Your line is open.
Thank you. Yes, one of you was talking about the issue of improving the delivery system. You mentioned not using fee-for-service. I think that was Antonio. And paying more based on quality. I wonder if you'd elaborate on that and whether the Roundtable had any position on other provisions like comparative effectiveness research or tort reform that's in House bills.
Yeah. The report makes a whole study of this. I'm going to ask Ken to go through that. Ken, please.
Ken? This is Ken Sperling.
Sure.
With Hewitt.
Hi, Joyce. In the report, there are suggestions for a number of delivery system reforms. Included in that are suggestions for medical liability reform, greater dissemination of evidence-based guidelines, as well as experiments in bundled payments and accountable care organizations, which have shown, in California at least, in the group staff models, to have a greater efficiency and higher quality of care through coordinated care teams, through investments in health IT infrastructure, through financial arrangements with providers that align the delivery of quality care and adherence to evidence-based practice guidelines. So it's something that we have seen in the past has had a significant impact on the efficiency and the quality of health care that is delivered, and we would support experiments in that direction.
Thank you. Can I ask one follow-up?
Sure, go ahead, Joyce.
One person said that the House bills expand, I want to make sure I heard this correctly, expand access more than the Roundtable was comfortable with, and I wanted to find out what they meant by that.
No, I don't think we've said that.
Okay.
What we said were the concerns with the public option were that it exacerbates the cost shift, doesn't innovate, and potentially takes people out of our risk pools, making it more expensive for our payments.
But we did say, John, that the House bills, various different provisions, do tinker with ERISA more than we think they should.
Yes. Yeah,
okay.
Very important.
And what's the problem with that? Tinker with ERISA in terms of giving you less flexibility?
That's precisely it, Joyce. They mandate, they both mandate certain activities, and they expand the state's ability to mandate activities within the states.
What kind of activities?
Well, to design state-specific requirements, to establish state networks that would be separate from the nationwide network, and would compete and contrast with the nationwide network that ERISA provides us, and things like that reduce our flexibility as employers in 50 states.
So that employers who didn't have to follow mandates under ERISA would then have to abide by them.
That's correct, and making our plans more expensive as they become less able to be consistent across all of our employee base.
Thank you.
You're welcome, Brad. I think that concludes the conference. Again, thank you for joining us today. If you do not have the report in front of you, it is available on our website, which is www.businessroundtable.org. It'll be posted there, and we thank you for your participation and thank you for your interest in this very important subject.